So I was telling you should also keep in mind about the combination therapy. Okay, you know that the aim of combination therapy is okay. You are ensuring that the cancer cells get killed, and you are also trying to avoid the resistance. But at the same time, you should remember about the side effect. Um, you see, okay, do you have the concept? Tell me clearly, honestly, do you have the concept of combination, fixed dose combination drugs? Like, let's leave aside the chemo, come back to the um, normal combination. Let's say paracetamol and anianacid and diclofenac. So why do we combine these two? Why do we combine these two?
More therapeutic efficacy, that's it.
What more? In what way it is more therapeutic efficacy?
Synergistic effects are.
Okay, what way? How come? Okay, see, go one drug by drug. Look at the paracetamol; it decreases your temperature. Okay, and look at anacid. What it does? Diclofenac, let's say. It also decreases the inflammation and thereby can decrease the temperature, isn't it? Sometimes inflammation could be a reason of fever. So basically it is anti-inflammatory drug. So it also decreases the inflammation and thereby decrease the fever. So here you got everybody. I think in this class agree that okay, we combine these two drugs and we got maximum more therapeutic efficacy than we would have got using individually diclofenac or paracetamol. Am I right?
Yes, sir.
Yes, sir.
Okay, now let's say by combining these two, you got a therapeutic effect of 10 units, let's say 10 units. And when you are using these two drugs separately, you are getting therapeutic effect of somewhere 5 units. Am I right? Am I right?
Yes, sir.
Okay, so now your unit of therapeutic efficacy is increased, but what about the side effect?
That will also increase.
That will also increase, but you know that here we took advantage of increased therapeutic efficacy by by mixing or by exploiting the properties that both the drug have same therapeutic effect. Okay, but you know that this both the drug does not have exactly same side effect also. What I mean to say is, you know that let's say NSA, diclofenac have nephrotoxic effect, and paracetamol has hepatotoxic effect. Are you getting me?
Yes, sir.
Arjun? So now, if you want to achieve the 10 unit of antipyretic effect only by using paracetamol, what you have to do? What you have to do? Tell me. Are you understanding me? Are you following me? Tell me. Are you understanding me? Tell me yes or no.
No, sir.
No, sir.
Okay, so tell me like that. You tell me. I'm repeating again. Do you have a paracetamol here? Can you see my screen?
Yes.
Yes,
Okay,
sir.
you have a
Yes, sir.
paracetamol here. You have a diclofenac here, and you are using both the drug to achieve a therapeutic efficacy. This is therapeutic efficacy. Okay, this is therapeutic to achieve a therapeutic efficacy of 10 units. Okay, clear. So if you use
Yes, sir.
paracetamol separately, you might be getting 5 units, and if you use diclofenac, you might be getting only 5 units. Okay. But if you use both, you are getting 10 units of therapeutic effect, which is decrease in fever or whatever. Huh? Okay.
Yes, sir.
Okay, so now what I want you to understand, okay, you utilize the property of these two drugs to get a therapeutic effect, to get a common therapeutic effect. But now let's imagine a scenario where you want to achieve a 10 units of therapeutic efficacy by using only paracetamol, okay, but not diclofenac. So what you have to do now? For example, previously you had given, let's say, 500 milligram of paracetamol, okay, 500, and diclofenac. Tell me the dose of diclofenac. Okay, so let's say previously you had given 500 milligram of paracetamol, 75 milligram of diclofenac, and then you achieved the 10 units of therapeutic effect. Everybody understood this till now?
Yes, sir.
Yes, sir.
Okay, now I'm asking you, you have to achieve the 10 units of therapeutic efficacy only by using paracetamol. So what is going to happen now?
Increase the dose, but the hepatotoxicity will also
Yes,
increase.
you have to increase this 500 milligram to achieve the 10 units only by using paracetamol. If you are not using diclofenac, if you want to achieve this goal only by using paracetamol, this dose may not be sufficient, and you have to increase the dose, right?
Yes, sir.
But you know that paracetamol is hepatotoxic,
Hepatotoxic.
and diclofenac is
Nephro.
nephrotoxic. Okay, you know this. So um, now when you are giving both the drug, you are giving in lower dose of both the drug. So there was less side effect to the liver and less side effect to the kidney, right? Right. Are you
Yes, sir.
following me?
Yes, sir.
Okay,
Yes,
Yes,
but
sir.
now, but
yes,
now,
sir.
but now, when I told you you cannot give diclofenac, you have to achieve this 10 unit of therapeutic efficacy, which is required for the patient here. If you are not giving 10 unit, the patient problem is not going to be solved. So you are increasing the dose here to meet this desire. You are increasing the dose here, but you are in increasing the dose and meeting the requirement. You should not forget that you are also troubling this. Am I right?
Yes, sir.
So this,
Yes, sir.
so what you understood from here is there is very much very good advantage by combining the two drugs, not only in terms of increasing the efficacy, but also saving the patient from getting the side effect, also sparing the patient from the side effect. This is the point I wanted to make with you. Is it clear now?
Yes, sir.
Yes,
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 sir.
sir.
Yes, sir.
Okay, so when it comes to, were you knowing this? Were you all knowing this?
No, sir.
Okay, so when you combine the drug, when you combine this any drug, it doesn't apply only to chemo drug, it applies to any drug. When you give a fixed dose combination, you even have to keep the safety parameter or side effect parameter in the mind. That's what it talks. This is the mool mantra of entire therapeutics. Actually, you have to remember whenever you treat patient with any kind of drug or any not only drug, even for a surgery, what is the risk benefit? Okay, whether the benefit is weighing more than the risk, then we need to proceed. So rationale of combining therapy, this is what we talked in the previous slide, why we want to combine many anti-cancer drugs, because they act through different mechanism at different stages of the cell cycle. We saw the cell cycle, no? So at different stages these drugs act, and this drug maximize or ensure the cell killing. That's why we prefer to combine chemotherapy, and of course this decreases the chance of drug resistance. So we prefer to use combination chemotherapy. This is just one example. This is just one example. Um, See, this C for cyclophosphamide, M for methotrexate, F for fluorouracil, A for doxorubicin. Here, this is the dose intensity. Okay, PR is for partial response, CR is for complete response. You can see the how potent the agent is. Okay, and see which agent causing how much of partial response and complete response. So CMF is the combination of cyclophosphamide, methotrexate, fluorouracil. CAF is a combination of cyclophosphamide, doxorubicin, and fluorouracil. So this is the partial response and complete response. So more is better to a point. Okay. So see how we go in the chemo actually. We for the advanced Hodgkin disease, this example, um, first we go for single agent, any single agent we choose. Okay, and then this FFP, can anyone guess what is that FFP? FFP is free from progression. Okay, so how slowly it is progressing. So this is one parameter in which we measure the efficacy of a regimen. Okay, so if we use single agent in Hodgkin lymphoma, in Hodgkin disease, the free from progression is 20%. If we go to MOPP, which is another regimen, then the free from progression is 63%. If you go from FFP to if you go from MOPP to 4 again ABVD, then it's the free from progression is increasing. So this is the point I want you to understand from this principle, that more is better to a point. But after that, it may not be very increasing. It may get stagnant. So this is another example. Docetaxel and doxorubicin cycle. You know, chemo is given in cycle. So this is taken from actually a study. But this is even we apply now in our practice. Okay, this is from world study around 2000, in the year of around 2000. So for cycle one, we for one set of patient they give docetaxel and followed by after that doxorubicin. In cycle 2, they interchange it, doxorubicin and docetaxel. And in cycle 3, it's up to the patient choice, okay, what they want to do. And here also they did, they started with dox, exactly opposite of cycle 1 and cycle 2 in the first sequence. They did opposite of here. And then what they found is it works. It works better than giving the chemo in other way. You will understand the rationale of giving this actually once we start the chemo cycle. Once you start understanding, okay, why we give in cycle, why we give this many gap time. So this is the dose, 40 milligram per meter square, 50 milligram per meter square of this drug. And you'll also understand in coming slide why we prefer body surface area in dosing the patient with anti-cancer drug. Okay? So this is the importance of sequencing in treating cancer. Osteosarcoma, you know, osteo means bone, sarcoma is the cancer of the cancer. So sarcoma of the bone, yeah, in 1917 surgery, if no evidence of surgery was the choice, if no evidence of metastatic disease. One half developed metastatic disease usually within 6 months of surgery. Actually, even after 6 months of surgery, around 50% of the patient develops metastatic disease, and 20% of the patient had 5-year survival. Thus, 80% had micrometastatic disease with adjuvant chemotherapy, 60 to 70% long-term survival. So I hope you know what is now adjuvant chemotherapy. Rasmi?
Yes, sir.
What is adjuvant chemotherapy?
Therapy
Adjuvant. We discussed in this class only what is adjuvant chemotherapy. Anybody?
The initial therapy.
We
So the
discussed
therapy
now.
given after the
We
surgery, sir.
discussed now what is.
Yeah.
See, we discussed what is neoadjuvant, what is primary, what is
Yes,
adjuvant.
sir.
So you should remember that. Okay. So adjuvant chemotherapy improves survival. That was the main point to take away from that slide. So this is again with data. In again, how many nodes were present? Like 1 to 3 node, and then if greater than 3 node, and with this, and then with this regimen, they compare which one is more effective. So this is something that we have already discussed about different stages of the cell cycle, and at which stage we should use this kind of drug. So this is again, I'm not going to go in detail. This is again +2 thing, and moreover we brushed up in the beginning class: interphase, prophase, metaphase, anaphase, telophase. So cancer chemotherapy, after completion of mitosis, the resulting daughter cell have two options. Either they can enter again G1 phase to repeat the cycle to differentiate and divide, or they can go into G0 phase and go into resting phase without participating in cell division. So cell fraction, growth fraction, this is what I was talking, growth fraction at any point, at any particular time, some cells are growing through the cell cycles, whereas other cells are resting. So how much cell are resting, how much cell are going through the cell cycle or cell division, that's a growth factor. The ratio of proliferating, so mathematically, what is the ratio of proliferating cells, that is cells in G1 and other phase, and what is the ratio of cells in the G0 phase. So that's called growth fraction, and this is important when you use the chemotherapeutic drug. So a tissue with large percentage of proliferating cells and few cells in G0 has a high growth fraction, because very few cells are resting and many cells are in proliferating stage. So we tell that the cells have high growth fraction, and the chances that the chemotherapy is going to attain such cell is very high. Conversely, if the cell is mostly in G0 phase, we call them as low growth fraction. All these things we have discussed. The anti-cancer drugs can act by damaging DNA, and you know all these things in detail, which are the drugs that acts by inhibiting the synthesis of new DNA that stop the mitotic process of the cell. So we also discussed the classification of cytotoxic agent, and like broadly you can categorize, okay, phase specific, phase non-specific, which acts on particular phase, and which kills the cell irrespective of the phase. So there's a difference. The drugs generally have a linear dose response curve, that is increased drug administration with increased fraction of the cell kills. That's the phase non-specific. Phase specific means above a certain dosage level, the further increase in the drug doesn't result in more killing. So, but you can play with the duration of infusion. What does this mean? Is phase specific, phase non-specific means, if you increase the dose, the fraction, the amount of tumor cell getting killed will increase. Okay, so that's a phase non-specific. Okay, if you increase the dose, but after reaching a certain dose, the killing will not happen. Okay, but you can still play with the duration. That means if you give the infusion over a long period of time, you can maintain better MIC for a long period of time, which can kill the cells, tumor cells more effectively. This is the concept that even we use in case of antibiotic. You see many antibiotic they give through infusion. Okay, have you noted that? Some antibiotic they give in a shot, but many antibiotics actually they give infusion over a prolonged period of time, like maybe 10 minutes, something half an hour, some 1 hour. So this is the reason actually. Of course, they are also nothing much different than chemo drugs. So two broad classes of chemotherapeutic drugs, cytotoxic agent, all these agents we have discussed, and the target therapy. This is something increasing now. This is the booming area actually. We don't want the side effect, because chemotherapy drug have so much of side effect, because it also acts on the normal cells. We don't want this drug to act on normal cells. We don't want the side effect. We want this drug to act on tumor cells only. So that's called target therapy. So we scientists design a drug in that way that it goes and identify only tumor cell and attack that cell. Okay, so there are many drugs coming up in the market, many monoclonal antibodies, many immunotherapy, which specifically targets only cancer cells and spares the normal cells. So some of the examples are erlotinib. These are small molecular inhibitor of EGRF tyrosine kinase. This is again growth factor receptor inhibitors. Again, there are some drugs like cetuximab. This is the antibody that binds to this growth factor. Then this alternating agent, antimetabolites, anti-tumor antibiotics, plaque alkaloids, then some of the other agents, hormonal agents, immunotherapy. This is what I was talking. This is the growing field now. We use host immune itself to kill the cancer. So we we make the host immune stronger to identify the cancer and kill the cancer right there, so that um, the other cells, the normal cells, doesn't get uh, affected. So route of administration, as I was telling, it can be oral, intravenous, intramuscular, or intrathecal, or intraperitoneal, intrapleural. So depending on what kind of cancer it is, okay, then it can be isolated organ perfusion, or intrapericardial, or sometimes in portal vein, on neem, or intraarterial. I hope you know all these route of administration from your pharmacology first year. So this is important, planning dose and schedules. How do you give the dose of chemotherapy? So based on body surface area, okay, this is very important. If the patient is having more body surface area, um, then you have to increase the dose. The patient may not respond to the normal dose that you give in the thin patient. This is unlike many other drug where we just fix the dose of based on age or based on body weight. So, but here we don't even consider body weight. We consider body surface area. Okay, so if the body surface area is more, we have to give more dose. And if you go back in drug discovery chapter like preclinical trial, clinical trial, when they fix the dose, okay, this is the dose of the drug that patient is going to receive in the in the trial. They fix the dose actually based on body surface area. Even in the animals, they look at the body surface area and they fix the dose. So this body surface area gives us the very precise idea of how much dose the patient will really need. And of course, this body surface area differs between children and adults, and this is adjusted for people who are elderly, who have poor nutritional status, who have already taken or taking other medication, who have already received or currently receiving radiation therapy, or have low blood counts, or have some kind of liver kidney disease because of taking in account of this side effect. Okay. So coming to schedule, that was about dose. Schedule, I was telling, no, cycle. So why do we give this drug, this chemotherapy regimen in a cycle? Cycle means one dose followed by several days without treatment free. Like we give a drug for one dose, and then we give a treatment free period, was a period, and then we give another dose. So why do we do that is, see, we give one dose, this is very toxic drug, this very potent drug, this is an anti-cancer, because they have to go and kill cells. And this also kills, as I told, we don't have much of the chemotherapy in the past, which act on a specific tumor cell only. They also kill the neighboring normal cells. So when you give a high dose of these toxic chemotherapy agents, they even are toxic to the normal cell. The normal cell gets killed. So because of killing of normal cell only, the patient is getting all these side effects: nausea, vomiting, diarrhea, baldness, alopecia, GI distress, all these things, like whatever side effect we have read, all these things are because of killing of normal cell. So we give a treatment-free interval. We don't give a drug. In that, what happens is tissue, the normal cells, the normal tissue recovers from the drug side effect. Okay, and the patient can still tolerate the next dose when you give. So that is the idea of giving this drug in several cycles, okay, and giving a treatment-free period. So it helps the patient immune system to come back, because these drugs are also immunosuppressant. This can make the patient vulnerable to get many other opportunity infection also. So giving that free time between two cycle helps the patient to helps the patient body to recover in many ways. Okay, so that's the idea of giving this drug in the cycle. The number of cycle will be decided based on the type, which type of cancer it is, and what is the stage of the cancer, and also on the side effect. Okay, how if the patient have experienced a lot of side effect, they may tweak the cycle schedule. Hematological consideration for the dosing schedule. This is important because most of these drugs are myelosuppressive drugs, and they suppress the bone marrow very profoundly, and patient have pancytopenia. So let's have a look at the blood cell environment. Platelet, the lifespan is 7 to 10 days. Red blood cell 120 days. Neutrophil 6 to 12 hours. So time from stem cell to mature neutrophil takes 7 to 10 days. The neutrophils are important because these are the first defenders against any kind of inflammation and all those things, and even in terms of immunity. So 7 to 10 days it takes from stem cell to get mature. So deciding on treatment interval, the physician try to make it as short as possible, and the patient should recover from the bone marrow toxicity, bone marrow side effects. So supplies mature cells in for 8 to 10 days, and 9 to 10 days. Onset is 9 to 10 days. Uh, so how the recovery from the bone marrow is happening? That's what we are discussing now. So supplies mature cell for 8 to 10 days. Onset is 9 to 10 days. Lowest is this terminology we use in medical. Nadir. Okay, when you say nadir, that means the lowest point in some cycle, in some stage. So lowest point is at 14 to 18th days. Okay, so 14 to 18 days is the lowest, and recovery starts by 21 to 28 days. Okay, recovery starts by 28. So this is how that is why many cycle, I think if you have seen, they do after 21 days or 28 days. Have you noted ever? Have you ever noted that? This is the reason. Okay, so usual schedule is every 21 or 28 days. So complication of chemotherapy, you know very well, because it also affects the normal tissue, normal cells. So myelosuppression, nausea, vomiting, stomatitis. What is stomatitis? Sorry, stomatitis. What is stomatitis?
Oral infection.
Not infection. It's the inflammation of oral mucosa. Okay.
Inflammation.
Yes, itis is there, inflammation. And then alopecia are the most frequently of the side effects. So these are some of the side effects summary. You know all of this: mucositis, nausea, vomiting, diarrhea, cystitis. It can even cause sterility, myalgia, which is bone pain, neuropathy, and these were some alopecia, pulmonary fibrosis. Okay, cardiotoxic. Some of the drugs are very cardiotoxic, like anthracycline class. Pulmonary fibrosis, we saw the side effect over there. Local reaction, renal failure. Some of the drugs like methotrexate can cause myelosuppression, phlebitis. So how do we, if you remember a table, how do we pick the responder? There in that table we had talked about PR and CR. So CR is complete remission, is the disappearance of all detectable malignant disease. Partial response is decreased if it is more than 50% in the sum of product of the perpendicular diameter to all measurable lesions. So perpendicular to the diameter, they measure how much. If 50%, then we call, if at least 50% or more than that, we call partial response. Stable disease is that where there is no increase in size of any lesion, nor the appearance of any new lesion. That we call as stable disease. Progressive disease. Do you remember we told one parameter? I told you one parameter based on which you based on which you see the progression of disease from one regimen to another regimen. So we call progressive disease if it increased by at least 25% in the sum of the product of the perpendicular diameter to of measurable lesion or the appearance of new lesion. So methods to increase the efficacy of chemotherapy. You give a standard dosing, then you give a high dosing, then dose density you have to do. So that's how you can do that. Then endocrine therapy. Okay, I'm again running out of time. I have just 10 minutes. I think I can complete it. So endocrine therapy, we can give many hormonal therapy. I think you know already about many of such drugs. We use many agonists or antagonists like anti-estrogen, estrogen antagonist, and for estrogen we use anti-estrogen. For progestin we use anti-progestin. We have aromatase inhibitors. We have gonadotropin releasing hormone agonist. We have somatostatin analog. So adrenocorticosteroid, these are as you saw, MOP, CHOP. What is P in that is steroid, prednisolone. Okay, so these are also a part of combination regimen, which are used for many cancers like lymphocytic leukemia and lymphoma. They function by binding to corticosteroid specific receptor present in this lymphoid cell, and they initiate the programmed cell death. The most commonly used agents are prednisolone, methylprednisolone, and dexamethasone. Okay, these three things you will see most commonly being used in the cancer. Actually, dexa very commonly. So anti-androgens, flutamide, this effectively block the binding of androgen to its receptor in peripheral tissue. It is used for the treatment of disseminated prostate cancer. Now, this is something again in a booming field in cancer therapy. Okay, biologic therapy or immunotherapy. We use the scientists are developing now the mechanism by which it can stimulate the patient immune system, and they can kill the cancer. Okay, we have many cytokines like interleukin 6, interleukin 12, interleukin 2, like interferon gamma, IP10. So all those things can help to kill the cancer. Okay, and that again immunotherapy, we have cytokines, as I told. Now we have some cellular therapy, we have some tumor vaccine. So interesting thing about is now I will tell you something interesting since it came about immunotherapy and cytokines. Do you know virus? What is virus? Hmm? Can you hear me?
Yes, sir.
What is virus? Quick, quick.
Microorganism which can't be alive without a host.
Okay, then how come this corona is without host spreading?
Spreading through the host only, no, sir.
No, we know, no, you know that it can survive so and so hour on so different surfaces. You know that or not?
So, but it needs host to reproduce, no, sir.
Okay, but do you know that no, it can survive on the outside the body for so and so hour, 12 hour, 9 hour on different surface.
But
Yeah.
not
But
for a
for
long time,
certain
sir.
hours only, sir, that's
For some time.
Okay,
ക്ലാസ് നടക്കുക
okay. Then tell me, uh, are virus harmful or beneficial? Why I'm asking this question is, we always, when I ask this, you might have perception, okay, virus can always be harmful to us. Okay, but when I ask about microorganism, bacteria, you do know that we in our bodies there are some of the bacteria which are even helpful, beneficial bacteria. Symbiotic association, if you remember, we had done that assignment. So we now we have the virus actually that we can engineer them and use for our benefit. Okay, there are many viruses actually, almost around 25 viruses that we can engineer them, and um, we take the virus genome out, we engineer them. Okay, we modify their DNA, we put back into them, and then we put that virus into the patient, and that engineered virus will go and attack only cancer cells. Okay, that engineered virus will not go and attack any other normal cells. So they once they attack the cancer cell, the interleukin, the cytokine will release from that cancer cell, and which in turns augment the host immune system to combat the cancer further. Okay, to combat such tumor further. This is just an overview I'm giving you. So this kind of therapy has come up already. Okay, we have the FDA have approved in 2015 a drug based on this. Okay, for treating melanoma, which is a skin cancer. So that kind of thing has already come up. Okay, so this it has many advantages. So in the next, what I'm going to tell is, in the next coming, I think around 20 years of time, the um, the environment, the science, the booming field would be about this. Okay, about biological therapy, about immune therapy. So new technology and drugs that allow cancer to treat target. Okay, a target cell. That's how we want to get overcome of these many other unnecessary side effect of the cancer. That's called targeted therapy. These are many drugs. These are some of the drugs of many drugs that is target based therapy and have successfully been used to treat cancer, like imitinib. Okay, imatinib, which BCR-ABL inhibitors. like cetuximab we're discussing. This is HER1 receptors, like Jeftinib. Okay, then I think you have bevacizumab. This thing you have read, no, in the classification. Rituximab, bortezomib. You have read this or not in the classification of anti-cancer drug? Which class you have read? We'll use this drug even in our coming diseases like breast cancers and all, like trastuzumab. Okay, so all these drugs we'll use in coming diseases. These are some more. Okay, based on like Veritac. So these are all, see, these are all intracellular. These are acting on intracellular signaling pathway. Death factor is FAS. So if it inhibits death factor, we have some drugs. We have some cytokine which can go and act through this one. So we have many drugs. Okay, we have many such drugs which can be used as targeted therapy. That's what is the moral to tell you from these two slides. Intracellular signaling pathway, that's an intracellular signaling pathway. So we have monoclonal antibody, as we saw many map in the previous slide as well, that fight with the cancer. EGFR, we have the growth factor receptor inhibitors. So these are present on cancer cells, but not these drugs will bind on this receptor on the cancer cell, but not on the normal cell. Tyrosine kinase inhibitor, that also we saw in the previous slide. There were many drugs that act through tyrosine kinase inhibitors. So this is again, you have to go back to your pharmacology a little bit to understand about this receptor and intracellular signaling pathway. And also, like, there is something called JAK2 pathway, okay, JAK2 stimulation pathway. So those things you have to go and read from here and from pharmacology also. You may get, I don't think you may get the question, but better to know, because in the coming days it will help you to understand the pharmacology in a better way. So this is how tyrosine kinase inhibitor acts. Okay, they fuse. Okay, and then intracellular signaling pathway goes in gene transcription, cell cycle, everything happens. This is a normal mechanism. Okay, this is a normal mechanism. This is how it happens. Okay, this is a normal thing that happens. Now I'll show you what happens with the drug. Okay, so strategy to inhibit this signaling pathway. There are some strategy like tyrosine kinase inhibitor we use. IBS, whatever drug you see IBS, they are tyrosine kinase inhibitors. So they go and block this. What we saw in the previous slide, the transcription is inhibited. Okay. So we have many monoclonal antibody, even they can bind and inhibit this. Okay, so the conclusion is very simple. Okay, we have many drugs now with which people can live longer. Initially, in the past days, we used to tell that cancer is deadly disease. The patient is not going to survive. The overall focus now is in quality of life rather than just increasing the lifespan. We try to make the patient live quality life, and the people surviving cancer want to live normal life. And new treatment of various kinds are available, and there is no need to suffer now, like the patient used to suffer in the past. So this was again general overview, general principle of the anti-cancer drug, or general principle of the chemotherapy used in cancer. Okay, with this, now in the coming next class